All right, so we have quiz 5. It's your last quiz, so that should be exciting, right? And then we will gear up for exam 3. I was going to say something else. Everybody got their assignments in. And then how are you guys doing with your HESI prep assignment? Good? Yeah, it's a lot, right? But that'll get you ready for HESI. Um, and then you just have your couple more NCLEX questions, your domestic violence case study, and then your vulnerable populations. And some of you have already turned that in as well. So good job for that. Um, Anybody have any questions before we get started with the quiz? Nope. All right. So I will put the password in the chat. All right. Password is in the chat. You have 15 minutes, 10 questions. You may turn your cameras off when you are done with the quiz. Just keep an eye on the chat. And password is 208 quiz 5. All right, so you guys did really good on your quiz. Does anybody have any questions?
Question number 2.
Question number 2. So question 2 is the nurse is caring for a client or for an immigrant who is pregnant with her first child. There are no vaccination records available. Which vaccine, I can't even say it, which vaccine should be prioritized? And so your choices were rubella, measles, varicella, and influenza. So the correct one is rubella.
Is measles the one that's a live one that they can't get when they're pregnant?
Mm-hmm. All right, any other questions? You guys did really good. All right, so who did did anybody read the readings for this week yet? Look over them, glance at them. All right, so I'll share my screen. All right, so for the readings for this week, it was chapter 5, which is care of the post-op surgical patient, cirrhosis. Then chapter 37, care of patients with diabetes and hypoglycemia, peripheral artery disease, chronic venous insufficiency, hypertension, and then chapter 9 is chronic illness and rehabilitation. And obviously it's the whole chapters here. You've got your page numbers. Everybody else, you guys are all in med surge too, correct? Or most of you are in med surge too?
Yeah.
All right, so, and then of course, in your Canvas course, you have under the modules, I'm sure you know that you have the readings, in your modules, and then you have the, additional resources that are listed as well. So the week 8 overview is going to give you your concepts. And then your week 8 reading is going to go ahead and tell you what page numbers and chapters. And then the next part of that is a section on addressing chronic diseases. And so it is a PowerPoint from the CDC. So if you haven't gotten a chance to look at that, I would look through it. Does give some really good information about diseases, about your chronic diseases. So the topics for this week, when we're, just for here, is home care, community resources, case management, and then of course the care of complex chronic illnesses in the community. And that's your cirrhosis, COPD, type 2 diabetes, peripheral artery disease, chronic venous insufficiency, hypertension, and your post-op care. So home health care is what we're going to start with. So as you know, community nurses work, and provide healthcare services in patients' homes, right? And so it could be in their home, it could be in a transitional care setting, or even in an assisted living facility. Assisted living facility, right? They provide some care, but they don't provide a lot of nursing care. And home care, I've even seen them go into nursing homes in some situations as well. And so home care does differ from other health, areas of healthcare, and being that we're going into their homes. And so what are some concerns or what are some things that I'm going to stop sharing for a second. What are some things that we need to be concerned about when we're going into somebody else's home?
Safety.
Safety, right? Not just for our clients, but for ourselves, right? Um, we have to think about, how safe we are, make sure that, there's things in place in order to ensure that safety is occurring. If you do not feel comfortable in a situation, then you need to not be in that situation. Um, and so traditional home health care is illness related care for individuals and their families, for homebound patients. Um, and so there's specific, definitions for patients that are homebound. Um, and so a lot of what your or part of your duty as a home care nurse is going to be providing education, right? So on the disease process, how to care for the disease process, how to use equipment, and it's not just for the patient, right? We're also going to be providing that information to family members as well. So one of the big things, um, you know, gosh, even, 10 years ago, um, most people that were transitioning from a hospital setting that were, recovering from surgeries, um, and, even newly diagnosed chronic conditions would transition into some sort of a skilled care or rehabilitation center, right? Get all the stuff that they need prior to being discharged. We are able now, with the technology that we have, people are able to be at home, right, with a lot of these complex chronic conditions that people are living with. And so that is something that, is going to be even more important. Think about it as the elderly population, continues to increase in size. And so we are going to provide for primary and secondary prevention. Um, and in some cases, there may even be telehealth services that are available. Home health care is not a constant, right? They're not normally in the homes for 24 hours a day. It's intermittent. And that's why the job of that home health nurse is to help them to take care of themselves, right? To facilitate that self-care so that they can remain in their home. And that does give the client some control over their life. It helps to prevent hopelessness, loss of self-esteem, right? It's also empowering to our patients, right? The more education, the more involved they have a little bit more control over what is going on. Um, and then, we kind of just work with them from there. So what are some services do you think that a home health care nurse would provide to a client in their home?
Wound care.
Wound care, absolutely.
They fill up their medicine boxes. They order new meds. They refill them. They check their weight.
Absolutely. Medication management, right?
They also
Educational.
can, if they need help with like food and stuff, they can call and get them set up in like the food pantry, get them set up on Meals on Wheels and stuff like that as well.
Right, because they have good links within the community setting, right? So they know kind of where to go. What else can they do?
ADLs.
ADLs. We can do IVs. So IV meds, IV fluids. We can do TPN, which is your total parenteral nutrition. They can do lab draws, urinary catheters, and then of course, changing them out, maintaining them. And then it's not always the nurse that's going in, right? There's also your CNAs, home health aides, right? So there may be delegation to member, the unlicensed assistant personnel. So that is something that, the nurse would take charge of as well. And so, how many people have ever thought about doing home health care? No, nobody wants to do home health.
I
It's
do it
different.
as I do home health also as being
Okay.
in the hospital. So I also have 2 clients that I see as well now as an aide.
Okay. So it is different, right? From go, whether you're seeing them in a hospital, seeing them in a transitional setting to, seeing them in their home, right? Where guests in their home. And someone wrote remove rugs. Safety is a huge issue. So like us, safety for not only us as nurses, but for our clients as well. And so that is sometimes, something that we do have to remember. We can make suggestions, right, as to what is safer for our clients, like removing the rugs, unscattering or uncluttering, I should say, in some cases as well, right? So that is something that we could do. The nursing assessment also may take a little bit longer when you're working in a client's home. It's really important for us to make sure that we are building that therapeutic relationship, not only with the client, but with their family as well. So the Omaha system is used by community-based nurses to document their client data. So it's how they implement their nursing process. And so the framework itself is used in a lot of other electronic record systems. But you're going to collect, right? And, collect all your data. You're going to assess the data. You're going to start your problems. You're going to identify an admission problem. And so Omaha system is something that's a little bit different. You're going to be the one, the RN normally, right, is going to do the admission assessment, and then the LPN can, assume care under the RN supervision. And so they will actually identify a problem rating using a classification system. They're going to plan, right? They're going to set up all the interventions. And then of course evaluate. So just it's just your nursing process, but it is the Omaha system. And with that, that's really important. That's where all the documentation that is required for that patient. And I have some friends that work in home health and say they say the documentation takes a little bit longer in a home health setting than it does in a hospital setting, just using the systems that are in place. But it is very effective. Other responsibilities of people coming into the house, whether it's a CNA, a home health aide, everything else is regulated by Medicare regulations, of course, your state licensing board, your organizations. And so we have to make sure that we're practicing within our Nurse Practice Act. And so collaboration is key. So a lot of times there'll be like team meetings between the RN, the LPNs, the CNAs, or the home health aides. And so making sure that everybody is clear in the responsibilities that need to be done for that patient. And so the everybody's heard of CMS, right? The Centers for Medicare and Medicaid Services. They are the ones that primarily, what's the word I'm looking for? Kind of set the bar, not only for documentation, but for standard of care, as well as reimbursement. So a lot of your insurance companies will follow CMS guidelines. And so the introduction to Medicare put a huge emphasis on extensive documentation for patients that are going into the home health care or into home health care. And like I said, 15, 20 years ago, some of the things that we're able to do in home health now, we couldn't have done. People would have to, if they needed IV antibiotics, they would have to be in some sort of a transitional care setting, like a skilled care center or skilled care rehab center, where we can do so much more. And so there's also still going to be a huge push for those cost control, right? As well as making sure we have really good patient outcomes. So other things, when we look at the living environment, so we do have to assess. If somebody did say like remove rugs from the environment. So we're looking for safety. We're, looking for those throw rugs, electrical outlets, extension cords, oxygen, low lighting, what are some safety things that you would think people transitioning from the hospital would need in their home to make sure that they're safe and secure? So, we talked about moving rugs. What are some other things?
Oxygen.
Okay, oxygen. Bars in the shower. Good job. Think about somebody that maybe has had a heart attack or has had a surgery. Okay. And think of those things. Bars in the shower are huge, right? What else could we do? What else could we help provide? Bedside commode. Okay, absolutely. What are some other
Night
things?
lights.
Night lights, adequate lighting. Yes. What else? Because we know, especially older people, right? They're at a big risk for falls, right? So make the stairs different color? Oh, that's it. I never would have thought about that. Okay, make the stairs a different color so the walls so they can see. Okay. What about, okay, so bedside commode is great. Or even what about an elevated toilet seat? So that if they are able to ambulate to use the bathroom, right, we can do an elevated toilet seat, right? So it's a little bit easier to get up and down. Shower chairs. Shower chairs are great too. Smoke detectors. Absolutely. Carbon monoxide detectors, right? Those are all things that we really do need to look at. So even like making sure that there's, handrails and grab bars, not just in the bathroom. We may need them by staircases. Sometimes if the staircase is enclosed with walls, right? They may not have what are those like arm rails going up and down. So we may have to make sure that those are I'm trying to think. Oxygen. What are some concerns that we have to worry about with oxygen?
Smoking in the house.
Smoking in the house. So we do have to make sure that there's no smoking signs posted outside the door to the home. And that the family is understanding that they cannot smoke with oxygen in there. Oxygen is highly flammable. We don't want to cause any issues. Heaters is a concern as well. Absolutely. Making sure that, if they're in a wheelchair, how accessible is their house, right? Regarding that wheelchair with the wheelchair, what are some things that we could do? What if something happened and they have a 2-story house, right? So how are they going to move around their house. Obviously, in a wheelchair, they're not going to be able to go up and down the stairs. So is there a way to set up their bed, on the first level? Do they have access to a bathroom? That kind of thing. Other things that we want to know, do they have food in the house? So somebody had mentioned that earlier, right? We want to know if they have food in their house to eat. Do they have help with household activities, right? Cooking, cleaning, doing laundry, right? Do they live alone? Because that's going to be depending on what disease or what, is going on with that patient, right? If they live alone, then that may, increase the need for services. Or, what's their support system? Do they have family close by? Is there somebody next door, like a neighbor that they're close with? Are they able to set up and dispense their own medication? That's a big one, right? Um, and then do they have access to healthcare? So just assuming that, just because they have home health services doesn't necessarily mean that they have adequate healthcare providers, right? So maybe they haven't been to the doctor and they had something happened and they ended up in the hospital, but they have not utilized healthcare services in a long time. We need to make sure that they have, that we get them, or provide them, with, finding a help with finding like a primary care and, making sure that they get the specialist resources that they need as well. And a lot of what we're going to do in addition to whatever care we're providing is going to be to provide education. All the education that we can give them in order for them to be safe and to get better and hopefully get back to at least, previous level of functioning otherwise or as close to as possible. And so, think about it. There's a lot of diseases out there. There's a lot of things that can cause somebody to have home health care, but making sure that they have basic information that they need. So, if they're post-op surgery, right, we want to, make sure that they understand the guidelines of, here are some of your post-op complications that can occur. This is when you should call your provider, go to the emergency room, call me as the home health nurse, right? Those kinds of things. And then any other support that we can provide through the home health agency. Has anybody ever worked with home health, like not not in home health, but like had a family member that used home health or anything like that? Yeah, some of the services that they provide are really good. I've had home health for myself. After a surgery, I had a PICC line and I had to get IV antibiotics. And so didn't need a whole lot of services because I was able to, use my pump and set up my own antibiotics. But they came out once a week. They drew my blood. They changed my PICC line dressing. And then, when the course of antibiotics was over, they are the ones that came and pulled my PICC line. So, it just really kind of depends on what services are needed by the patient and the family. And say who started working on their vulnerable populations project? So one couple, maybe. All right. So all right. Has anybody done any research so far on their vulnerable populations? So, what are some things that you noticed in your community that were either available or not available to people?
So we have a lot of drug overdoses, and I've noticed that we don't have a lot of places or a lot of people, um, that knows what Narcan is and how to properly use it. Um, Especially around like the homeless community. That's where a
Mhm.
lot of those are. Um, So I have noticed that, that is one of the biggest things is there's not a lot of advocating about what Narcan is and how to use it, and that like the health department does offer the class of the Narcan to learn how to use it, and they do give you samples to carry with you.
Mm-hmm.
They don't really advertise that. So I have noticed that.
Okay. So, and that's scary because you can literally go to Walgreens or CVS or anywhere and buy Narcan. Like it doesn't, there's so not having the education, not knowing how to use it is, you're right, that is a definite need. Um, So, okay, so definitely looks like you found something in your community that is needed. But community resources are used to enhance the self-care capacity and used to help with managing chronic illness, as well as helping to reduce vulnerability in our vulnerable populations. So what are some common resources that most communities have? Just think about some of, what are some of the things that you see, when you're driving to and from work or to and from school, to and from, the grocery store? What are some things that you see that are available for the community? What are some resources that you see?
Clinic.
Clinics. Okay. What else? What are some community resources that are available in pretty much all areas?
In my area, we have a food pantry and we also have a lot of rehab facilities.
Okay, rehabs, food pantries. Awesome. What about health departments? Pretty much every community will have a health department. The size, the availability of services is going to vary from area to area. Telehealth, yep. Um, Volunteer organizations. What about Meals on Wheels? Anybody ever seen Meals on Wheels driving around? Okay. Red Cross. So the American Red Cross is out there as well. Food banks, clothing banks, domestic abuse shelters, churches, there's all different types of services that, a lot of areas have, depending on the size of the area and, the availability, but those are some general good ones. Domestic abuse centers or shelters, they don't have signs on the building that say, hey, we're here to help, we're a domestic abuse shelter, right? They try to keep that information private, and only people that, are in need are going to be able to know where that is. And that's just for the safety, right? For the people that are in those shelters. So you may not see, but they, I don't know how, they are available to people. Let's just put it that way. Churches, anybody's area do a night's welcome? Has anybody heard of a night's welcome before? So a night's welcome is something I used to volunteer when I was doing Boy Scouts. A night's welcome, churches will do it. The one church that I volunteered at, it was for a week. So they did it for a pretty long amount of time, but they would provide the homeless population, they would give them dinner and they would give them a place to sleep for the night. And then during the day, there would be a bus that would come and take them so that they could go shower, or if they needed to go, to an appointment or, whatever. There was limited transportation, but there was transportation for certain things. Sitter services, trying to think of the one sitter service I see all the time. And I can't remember the name of it, right? But sitter services, and these aren't always, healthcare providers. These are, lay people that offer services to come sit with family members or even babysitting in certain situations. How many of your all's communities have adult daycare centers? Has anybody seen an adult daycare service or adult daycare center? So things like PACE, have you guys seen like PACE services? So those are a lot for our elderly population. They, get picked up in the morning by, transportation. They're taken to, it's an adult care center. This way, especially if they don't drive anymore, they're traditionally, don't have a lot of interaction, socialization. So this is a way for people, they get together, they socialize with people their own age. They are provided meals. I don't remember if it's 2 meals or 1 meal. And then they're brought back home in the evening. A lot of those PACE services as well will offer, sometimes they have providers that are there on site. So if they have, their primary care, there's also nurses and other healthcare members there that if they need additional assistance with things, additional education, right? So there's a lot of things in our community. We may not always see them, but really kind of just looking around and seeing what's around in your community when you're doing your vulnerable populations project is really going to kind of open your eyes to see what's lacking or needed in your community. And even for, I didn't know we had that kind of thing. And so with non-English speaking communities. So there's all over the United States, there's areas that we have a large amount of non-English speaking population, especially with our immigrant community. And so these are part of the community resources that are available as well. Long time ago, don't remember how long ago, during my bachelor's program, I did my clinicals for community nursing at the health department. And one part of the health department is where anybody that is immigrating in, they'll go to the health department, and this is where they get set up with services. And so, they get, things like signing up for food stamps, housing assistance, their immunizations, and, help with finding healthcare providers, and things like that. And so they always have that resource at the health department in order to help integrate them into the community. So that is something that a lot of your health departments may have as well. I just thought it was really cool that they did that. Our health department stayed really busy with that as well. And so what is the best way to work with? So what do we do when we are working with somebody who doesn't speak our language? What is the best way for us to communicate with them?
An interpreter.
A professional interpreter, right? Professional interpreter is going to be our best bet. Why don't we want to use family members or kids?
They can leave out information to or from the provider.
They can leave out information, whether it's on purpose or accidental, right? They may not understand some of the things that we are trying to explain. It could just get lost in translation as well. So we always try to make sure that we are using professional translators. And there's a variety of different ways that we can do those as well. And then the last part, before we talk about chronic diseases, is case management. Who has anybody heard of case management before? Yes. So case management, right, is we can, indicate it, or it's indicated for a variety of healthcare settings. So we do have case managers that work in the hospitals. We have case managers that work with insurance companies and home care as well. It's just, the job of the case manager is great. They have a huge responsibility. But some of the things they do is promote interprofessional services. They increase client and family involvement. They help to decrease healthcare costs. And, by having somebody help them to manage their disease, right, that eventually will lead to improved client outcomes, right? So if I have a client that, say I have a newly diagnosed diabetic that's being discharged from the hospital. Now we're going to give them education in the hospital, right? We're going to talk to them about their disease. We're going to show them how to, check their glucose levels, right? And take their medicine, or either that or use, how to drop their insulin. And then we discharge them home. If I discharge them home and there's not a whole lot of follow-up, what do you think is going to happen to that diabetic?
They'll be back.
They'll be back. Exactly. And that's not what we want, right? I mean, we're going to take care of them, right? If they come back, but the goal is not for them to be readmitted to the hospital. And there are case managers that are specific to, different disease processes. So there are diabetic case managers, right? So it just kind of really just depends. And so that's how, if the case manager is there to answer questions, to follow up with them on how it's going, follow up with, for diabetic, right, their dietary needs. So that does help to improve patient outcomes. Also helps to reduce gaps and errors in care. So again, I'm just going to use diabetes because we know that that can be a lot on somebody, right? So they have their primary care. They may need an endocrinologist, right? They may need a nephrologist. They may need a podiatrist, a neurologist, right? There may be a lot of people involved in this one person's care. So that's one thing too, a case manager can help, is to kind of bring it all together, help them to schedule appointments, make sure that they are going to their appointments, so that they get everything that they need. So they help to really bridge that gap. And there's specific pathways that case managers use as well. But it's going to be for the case managers or for those high cost chronic diseases. So diabetes is a high cost. What other diseases do you think would be considered high cost, like, to treat and manage?
COPD.
COPD, absolutely. Absolutely. Anybody else got any? About liver disease and cirrhosis, things like that, right? Those can be very high cost as well. Again, it's gonna be, their case managers. I I spent a week with a case manager as well during my bachelor's program. I don't know how she did what she did, because can be very labor intensive to be a case manager. It's, can be very time consuming as well, right? Depending on, oh no, okay. And so, their caseload may be extremely high, right? So we do have to, it's a lot. I think the caseload for the lady that I worked with, she had 40 patients, or 40 patients that she was following. And in like one of her patients, she said it was a daily check-in, like she had to check in with him on a daily basis. And again, they're dealing with chronic illnesses, and gonna have a higher amount of needs. And so, one of the challenges with your case management is fragmenting of services, which either results in either overuse of services, underuse of services, gaps in care, miscommunication. One thing that most I'm going to just ask this. Who's ever gone to, let's say you have a need, something happens, like let's say, I'm just going to use a hangnail because, nobody likes a hangnail, but you go to your doctor, right? Because you have this hangnail and you need it taken care of. And your primary care was like, oh, I can't do that. I have to send you to a specialist to handle that, right? And that, sometimes we get a little bit frustrated with our primary care because they just seem to want to just send us off to a different, right, specialist in order to handle what those situations are. And so, that the one thing about that though is even though your primary care provider is sending you to specialists, right, for whatever different reason it is, they are still coordinating that care, right? Because all right, so you went to your primary care, they sent you to this specialist, then that specialist is going to send information back to your primary care, right? So they're kind of coordinating whether, it gets frustrating sometimes or not. But that is one provider, right? You'll remember your primary care. You may not remember going, the name of the specialist that you went to see one time, right? But your primary care will have that information. So those case management nurses obviously have to have really good time management skills. They have to have really good communication skills, because they're the ones that are going to facilitate the communication amongst, all the parties involved. So all the different specialists, the primary care, the patient themselves, family members in some situations as well, right? So, they also may even have to reach out to payer sources, to kind of advocate for certain things as well. Also have to know all about the community resources that are available, right? So when your client calls and says, hey, I'm having trouble, I can't pay my mortgage this month, I can't pay my rent this month, because I was out of work for so long, right? Then, that case manager has to have an idea or understanding of what the services are and the community resources that are available to help their clients. And also have to have really good conflict resolution, critical thinking skills. All of these are going to be super important, super, super important when we're working with members of the community. And then they have to maintain that nursing care plan. So, that's another thing that's within it. Communicating with patients is probably, the communication with patients is going to be different than the communication that you're going to do with other providers, right? So different types of communication are super important as well. And one thing too is what's good for one client is not going to be good for the next, right? So what worked for, patient A may not work for patient B. And so they have to be really flexible and able to move around, and kind of, be able to deal with different situations. So it's really interesting to see what they do. They've even, they'll call and make appointments. They'll make sure that they have transportation. In some cases, they'll be the ones setting up the transportation for the client. Let's say if they have, a medical need or, their insurance is able to cover their transportation, they'll actually set it up and, do all of that stuff. So and care management case management is a really good thing. They even have things like health coaches. Has anybody ever heard of a health coach? Yeah. So, my daughters are both nurses as well. So my oldest daughter is an RN, my youngest daughter is an LPN. And my youngest daughter works as a health coach. So it's not really case management, but she has a specific client, she has a specific set of clients that she works with. And it's basically just, it's very similar. She provides education. She calls in to check on, certain things or medications, their glucose levels, their blood pressure, and other things. And then if there's any issue, she's kind of the go-between between the client and the healthcare provider. So rather than, having them have to, go to the doctor, for things that can be handled, over the telephone, she's kind of that in-between person. And so she has, a set of guidelines that she follows, and then she can communicate directly with the provider. And then the provider can say, okay, well, they don't need to be seen, but we need to do this, or yes, they should be seen, right? That kind of thing. And so a lot of cases, it's just kind of a go-between person. So it's, it's something that she enjoys doing. There's something I wanted to say. Because, sometimes, especially now, finding, you wake up in the morning, you don't feel so good, right? You call your doctor's office, you may not be able to get in, right? For a couple of days. And so that's where that, transition kind of does help. All right. Any questions on home care or case management? So we're going to talk about some of the chronic complex illnesses. So again, your cirrhosis, your COPD, your type 1 diabetes, your peripheral artery disease, hypertension, post-op care, that kind of thing. So post-op care, what are some major concerns after somebody has had a surgery? What are we worried about?
Bleeding.
Okay, bleeding, infection, bleeding. What else? DVT, absolutely.
Their gag reflux.
Their gag reflex. Okay. Airway, breathing, circulation, right? Covered all of those. And so pain is another thing that we worry about, right? We don't want people to be in pain. They are going to be in pain, but we are going to try to alleviate that as much as possible. So what are some of the airway issues that are possible after surgery?
What do you mean, like shortness of breath?
So shortness of breath can happen, but like so somebody has had surgery and they've been intubated. What are some of the complications? Pulmonary embolus? Yes, absolutely. Collapsed lung, atelectasis, very good. Pneumonia, absolutely, very good, right? And then even if we're giving them, what if we're giving them Dilaudid or morphine or fentanyl? What else are we doing to the respiratory system?
Depressing it.
Right, yes, we're depressing their respiratory system, right? So we got to make sure that they're breathing. And so what are some things that we do for our clients after surgeries, or we recommend that they do after surgery for breathing?
Is it just
Incentive
barometer?
barometer.
Incentive spirometer, turn, cough, and deep breathe, right? Those are what we want to do. And of course, ambulate as soon as possible if we can, right? All right, what are some things with how could we prevent a DVT? What is a DVT?
Deep vein thrombosis.
Okay. What are some things that compression stockings? Yep.
Those things in the hospital where they stick on your legs and it pumps up with air and
Very good. SCDs. Yep. So your sequential compression devices. Great. Adequate hydration and movement, range of motion. Somebody said it, right? That's the best way. We don't want that blood to, just kind of pool in the back of those legs. Dehydration could also be when Melissa said adequate hydration, dehydration is a potential issue as well. Right? We normally will have them fast, right? For prior to a procedure, so they have not had anything to eat or drink. And yes, we may be giving them some IV fluids just during the surgical procedure. But still have to make sure they stay hydrated. What if people have, reactions to anesthetic or anesthesia? Nausea, post-op nausea and vomiting is another issue, right? That's just going to further their dehydration. What if we had a Foley catheter inserted during the procedure? What does that put them at risk for?
Infection.
Infection, UTI, right? And in our older population, a UTI can lead to sepsis very quickly, right? If we're not careful and watch that. Somebody said bleeding, right, is a post-op complication. So wound healing, right? Infection is huge, right? Making sure that, we're keeping that surgical site clean and dry and intact. What if I have a patient that had major surgery and they're going to be in bed for a while? What are some other risks involved there?
Ulcers,
Ulcers,
like
absolutely.
pressure ulcers.
Yep, your pressure ulcers, right? So then we have to look at what interventions that we can put in place to prevent pressure ulcers. In addition to the morphine causing respiratory depression, what else can morphine cause? Or any of the pain opioids?
Constipation.
Constipation, right? So nobody likes to be constipated, right? So making sure that we're increasing fluids, right? Fiber, maybe a stool softener. We want to make sure that we keep their bowels moving. What are some ways that we can help to prevent that wound from becoming infected?
Nutrition first and foremost.
Absolutely. Nutrition is very important. What else? Education on signs of infection. Absolutely.
Is it
Cleaning.
turning them every 2 hours? Yeah, cleaning methods and supplies.
Yeah, make sure that we're using that aseptic technique, right? When we're doing that surgical dressing change. Most surgeons, and I'm gonna just say surgeons, most surgeons, right? They don't want you touching their dressing, right? They put that dressing on while you're in the OR, and they generally don't. They want to be the one that's going to do that first dressing change, right? So a lot of times we're going to monitor that dressing while, until they come and change it. And so, it may just be reinforcing, right, the dressing until they can get in there and see it. There was something else I wanted to say. Well, somebody said eating. What nutrients are really important for wound healing?
Protein, vitamin C, zinc.
Protein, vitamin C, and zinc. Absolutely. Good job. During in that post-op period, so LPNs can delegate some activities to our unlicensed assistant personnel. Just remember that when we are delegating, that we're giving specific instruction on what needs to be done, making sure they know what needs to be reported back to us. And, because you or me or whoever is the one delegating is ultimately responsible, right, to make sure that those tasks get done appropriately. So what is cirrhosis?
It's a disease that destroys your liver.
Okay, it's a disease that destroys the liver. What are some of the common causes?
Alcohol.
Alcohol.
Overuse of Tylenol or ibuprofen.
Yep. Alcohol is probably one of the biggest one, as is your hepatitis B and your hepatitis C. And so, yes, so the liver cells are destroyed. It's replaced with fibrotic tissue, and that fibrotic tissue can't function appropriately, right? And so when we look at that, if the tissue is fibrotic and it doesn't function appropriately, that also is going to disrupt blood flow through the portal circulatory system, which, if the blood backs up in that portal system, it's going to leak out into the abdominal cavity and cause ascites. Has everybody heard of ascites before? Okay, so ascites is just fluid in that peritoneal cavity. And so another thing too is if my liver is not working and working appropriately, it's not going to be able to produce enough albumin. And if you remember, one of the major functions of albumin is to help to keep our blood in our blood vessels, right? And so if I don't have enough albumin, then blood is going to be able to leak out of my blood vessels, and that also contributes to the ascites. It also contributes to the formation of edema. And generally it's generalized edema. So it's not just in the ankles, it's going to be all over the body. They'll generally be very fatigued, they'll be weak, they'll have headaches, obviously abdominal pain as well. Again, my liver's not functioning, so I'm also going to be at risk for bleeding, because I will have a decrease in my clotting factors, because that's another thing that the liver does as well. So they may start to have the symptom, they'll, start to have some of the symptoms of that. So everybody's heard of jaundice before, right? The yellowing of the skin. You're going to see it first, usually in either the conjunctiva or in the eyes. If they have pale colored stools, dark urine, that is usually another sign, that there's issues with the liver. So what are some interventions that we would do for this population? What do you think we could do? I've got a whole lot. Let's just all start with fluid. If I have a whole lot of fluid, what is an intervention? If I have a whole lot of fluid in my body.
Furosemide, Lasix.
Okay, diuretics. Okay. And fluid restriction, sodium and fluid restriction, right? Don't want to give you a whole lot more fluid, right? Until we can get some of the fluid off. Put them on fall precautions. What about for my vitamin and mineral deficiencies?
Replace it.
Replace it. We got to be very careful though, right? So
Potassium.
yeah, potassium is one of the biggest ones. We do have to be careful when we're looking at replacing those vitamin and minerals, because it could actually even cause worse damage to the liver. So even though they're going to be depleted, we have to be very careful when we're replacing them. Medications that affect the liver, we also, right? If my liver isn't working appropriately, we got to be really careful with those. Somebody said acetaminophen earlier, right? That's one of the big ones, especially that over the counter. Who doesn't turn to Tylenol, right? When they have a headache or a fever. Want to make sure that we're giving, they're getting adequate calories, adequate protein, right? When people have an active disease state, right, then their metabolic rate is higher. So they have increased nutritional needs. We'll do daily weights to monitor fluid status. We're also, because of the ascites, we're going to measure their abdominal girth, right? So if their belly is full of fluid, right, we can kind of see, by measuring the girth of the abdomen, then we can tell if the ascites is getting worse or if it's getting better. And so big thing with this too is they need to stop drinking, right? And try to prevent further progression of the liver disease. What is COPD? What's COPD?
Lung disease.
Coronary obstructive pulmonary disease.
Okay, yes, chronic obstructive pulmonary disease. What are some of the causes of COPD? Tatiana, what are some causes of COPD? I think Tatiana has me on mute. Exposure to chemicals. All right. Smoking, right? Big one. Even secondhand smoke exposure can be another. So they will, this is going to include your chronic bronchitis. It's going to include your emphysema. Yes, some are job related. Absolutely. So has anybody worked with a patient with COPD? Yes. What are some of the interventions that we're going to do for a patient with COPD?
Not being stingy with the oxygen.
Not being stingy with the oxygen, okay?
Make sure they're sitting up.
Yeah, take periods of rest.
Periods of rest, yep. Small, frequent meals, yes. Cluster care, okay. So other things, quit smoking, right? We want them to quit smoking. We want to reduce exposure. So if it was work related, if it's, work, another, outside exposure, right? We want to, we want to try to stop whatever the exposure was, right? It's not going to reverse the process, right? But it could prevent it from, worsening. And so the small frequent meals, COPD patients, if you really look, especially in the later stages of COPD, they're very thin looking, right? Very kitchetic looking, right? Because imagine you're trying to even drink. If you're short of breath, right, it is very difficult to drink and eat, right? So think about, say you just ran 3 blocks, three times around around the block, right? And then somebody just put your dinner in front of you, right? Imagine you're huffing and puffing and trying to eat, right? So that's what these people go through all the time when they're trying to eat. And so we want to make sure that they are getting the nutrients they need. So those 3 small, small frequent meals. We also may have to do like some dietary supplements as well, right? To help them to increase their calories. Somebody said, don't be stingy with the oxygen. We are going to do oxygen, but we do have to be very careful with the patients that have COPD, because in some cases the oxygen can actually suppress their respiratory drive, right? So somebody that is really short of breath, we're going to do low flow oxygen initially, right? Their bodies have become accustomed to the high CO2 levels. And so when we give them too much oxygen or too high, it could potentially suppress their respiratory drive. And then of course there are medications, right? They're in bronchodilators, they're corticosteroids, right? Making sure that they know how to use inhalers. Anybody ever seen somebody use an inhaler and you're like, you did not do that right? Right? So making sure that they know how to use their inhalers. That is super important to maximize, right? That's where your spacers come into play as well. And then making sure they get their flu and their pneumonia vaccine. Diabetes, right? Type 1 and type 2. What are the 3 major symptoms of diabetes?
Polyuria, polydipsia, polyphagia.
Very good. Yes, Marion, you are absolutely correct as well. So your 3 Ps, polyuria, polydipsia, and polyaphasia. So excessive urination, excessive thirst, and excessive hunger. We look at early diabetes and pre-diabetes. We know those are potentially reversible, right, with diet and exercises, weight loss, stress reduction, right? So somebody that's been diagnosed with, early diabetes or pre-diabetes, right? We want them diet, exercise, right? Make those lifestyle changes, and that will help to prevent it from going into, the full disease process. Biggest things that we worry about with diabetes is that good glucose regulation, right? Um, because with diabetes, right, it's those long-term macro and microvascular changes that we are hoping to prevent, right? And so whether it's, the neuropathies, the retinopathies, the cardiac complications, the better control we have of those glucose levels and keeping them within normal limits, the better, potential outcomes that they have. They'll hopefully have fewer complications. What are the signs and symptoms of hypoglycemia? So I use it's not an acronym. Shaky, cold, okay. So hot and dry, sugar high, cold and clammy, gimme candy. Okay. So cold, candy, shakiness. Yep. Yep, Michelle, that's exactly where I was going. That's my favorite one to remember as well. So what are some things that we can give our patient if they are hypoglycemic? So candy is good. Especially if it's really low, anything that has a really high sugar sauce. People have seen the little glucose gels. They don't have glucose gel cake icing, the little tubes of cake icing work just as well. Um, Juice, soda, milk. Yes, I was hoping somebody would say milk. Milk is absolutely wonderful for somebody that is hypoglycemic. Anybody know why? Do you know why, Michelle? Or just know that that's you, and that's okay if you don't.
Is it the calcium
Sugars and fats.
and the fat?
It has carbs. So it's,
Oh.
yeah. So what it is milk has protein and carbs, right? And so it helps to bring your glucose levels up, but it also helps to maintain glucose levels. So like think about like, giving somebody the glucose gel, right? That's going to bring that glucose level up really quickly, right? But it's not going to be sustained, right? If we don't give them something else, then their sugar is just going to drop, right? And so that's what's nice. It has the carbs to help bring the blood sugar up, but it also has protein in it to sustain it. That's why like the nabs are really good. The little peanut butter cheese crackers, you know what I'm talking about? Those are really good for the same reason because it will help to bring the sugar up and then it will help to maintain it. Yeah, almonds as well. So we do need to get the sugar up quickly, and we can do that with the juice and the candy and the regular sodas and things like that. But we also have to look at sustaining it. What else? Um, and we only have a few minutes. PAD is your peripheral artery disease, is usually related to atherosclerosis, right? Which is a buildup of plaque in the arteries. It commonly affects your lower extremity arteries. Who's heard of intermittent claudication? Nobody's heard of intermittent claudication. So intermittent claudication is, you get up, I always think of this as like, you get up and you start walking around and you get cramp. Yeah, pain gets worse with exercise. And so you got to sit down, right? And so the pain is relieved and it's a lot, this something that patients will experience if they have PID. must also have some tightness in the calf legs or the calves and buttocks as well. And they also may have some ischemic changes, right? So if I'm not getting good blood flow to my extremities, right? Some of the things like when you go to check those dorsalis pedis, posterior tibialis pulses may be a little bit weaker. Their skin may be very pale, they may be very thin, very shiny skin, may not have any hair on their top of their foot or their toes. And they can also develop ulcers. The problem is, right, if I have peripheral artery disease and I'm not getting good blood flow to my feet, those ulcers that are developing are, going to be very difficult to heal. And so a lot of patients end up with, gangrene or necrosis in those areas that they end up with amputations. Best thing they can do is to continue to exercise, just rest when the pain starts, because that is going to help them to improve their circulation. With PAD, we don't do any kind of compression. So that's something really important to remember. With peripheral artery disease, we don't compress the extremities. So, no real tight shoes, no tight leggings, jeans, that kind of thing. And so, because that can actually make it worse. Always want to keep the legs. We also, elevating isn't going to help as well. We always want to keep the legs level with the heart. That helps to improve circulation. On the flip side of that, with chronic venous insufficiency, this is one of the big differences between arteries and veins is that the veins have valves, right? And so with chronic venous insufficiency, this is a issue with the valves. So the valves in the veins aren't closing properly. And so, the blood ends up going backwards. And so, sorry, which leads to the swelling in the lower extremities. Blood can actually leak out of the blood vessels just from the pressure. And patients that have venous insufficiency, they have like brown leathery skin around their ankles. Has anybody ever seen that before? So that's how you tell the difference too. If they're, if it's pale, thin, and shiny, then it's arterial. But if it's like brown and discolored and thicker, then that's a venous deficiency, venous insufficiency. And so the skin is very scaly, it's thick. And ulcers are common as well with chronic venous insufficiency, except they're usually within the ankles, around the ankles. They look very irregular. And they usually have a whole lot of drainage, right? Because the blood, we have fluid leaking out of the blood vessels. So they usually have the lots of drainage with those venous ulcers. With venous insufficiency, this is where we want to use compression. So we can do the compression stockings, we can do compression bandages. We want to make sure that we are elevating the legs, and then, that will help to improve. So with arterial, right, we want to keep everything level. We want them moving. We don't want to compress, right? And we don't want to elevate. With with venous, we want to elevate and compress. All right, so that's two different things between arterial and venous. So any questions?